everyone. Thank you for joining us. Welcome in. We'll give everyone a moment to log on today. Thank you for joining us for this webinar. We're glad you're here today with us. Hello, hello. Thank you for joining us today for the webinar. We will get started in just a moment. Thank you for joining us as you're coming in. We will go ahead and get started. Welcome everyone to today's Schwartz Center Compassion in Action webinar, Supporting Mental Health and Preventing Health Worker Suicide. Thank you so much for joining us. I'm Angelina McCoy, Member Experience Manager at the Schwartz Center. As many of you know, we are a Boston-based nonprofit organization established in 1995 to advance compassion in healthcare. Our vision at the Schwartz Center is that everyone who provides and receives healthcare experiences compassion. Thank you for joining us today as our panel discusses supporting the mental well-being of healthcare workers. Before we do that, I'd like to share a few details about what you can expect. Please note that the program will last for 60 minutes with a panel discussion for about 45 minutes, followed by some time for questions. Feel free to enter your questions in the Q&A pane throughout the discussion. I'd also like to acknowledge with gratitude that this Compassion in Action webinar series has been funded in part by a generous donation made in memory of Julian and Eunice Cohen. With that, I'll hand it over to Dr. Beth Lown, Associate Professor of Medicine at Harvard Medical School and Chief Medical Officer of the Schwartz Center for Compassionate Healthcare. I know she's excited to get the conversation started.
Thank you, Angelina, and thanks to all of you for joining us. As you may know, September is Suicide Prevention Month, so all month, mental health advocates, prevention organizations, survivors, allies, and community members are coming together to promote suicide prevention awareness. Mental health and suicide prevention is of such critical importance to all of us. Researchers have shown that depression, anxiety, and other psychological and psychiatric issues are not at all uncommon among health workers, and suicide is more prevalent among nurses and physicians, particularly female physicians and the general population. And while there's certainly work to be done, what we really want to stress today is that there's very important work happening, particularly in addressing drivers, reducing stigma, and increasing access to mental and behavioral health. Please note that we will be talking in this webinar about mental health and suicide. The new 988 number for National Suicide Prevention Lifeline went into effect in July of 2022. It is staffed by trained counselors. So if you or someone you know is struggling or in crisis, help is available. You can call or text 988, and you can also reach the crisis text line by texting home to 741-741. And so with that, I'm happy to introduce you to our guests today. Jennifer Mensik Kennedy, who is president of the American Nurses Association, Christine Yu Moutier, who is chief medical officer of the American Foundation for Suicide Prevention, and Judy Davidson, nurse scientist at University of California, San Diego, and research scientist for UC San Diego School of Medicine, Department of Psychiatry. It's really a pleasure to have all of you with us today. And with that, I'm going to ask Jennifer to get us going here.
Get myself off of mute, and I am going to share my presentation. So there we go. And I'm assuming everyone can see my slides.
Yes.
Perfect. Well, it's an honor to be here, and this is such an important topic. As we've discussed, this is an event for all of September and for all of the year. And the more we can talk about this and have everyone feel comfortable about this topic, talking to their colleagues, talking about it for themselves, we'll make an impact. And I truly believe that. So, and thank you for having this webinar on this topic. I think part of, the nature of whether it's nurses, our physician colleagues or pharmacist colleagues, we're all in the top most trusted and ethical from the Gallup survey. And people, the community, and our patients can trust us to do the right thing. They know that we're going to put them first before ourselves. And there comes some obviously downside to this is where we start to see the depression and the anxiety, as we know we're struggling to take care of everyone, but we may not take care of ourselves in our roles as healthcare professionals. A little bit about the ANA, because we have a couple of different surveys I'm going to talk about from a couple of our different subsidiaries. And the American Nurses Association includes our foundation partners, which have done our COVID series for the last several years, as well as our main ANA body, which has done our Healthy Nurse, Healthy Nation surveys for the last 5 years. So I'm going to talk a little bit about that through our work. So we'll kick it off a little bit about our COVID-19 series. And this is where our American Nurses Foundation decided that with all this stuff going on early, that we needed to do something to kind of gather the data and understand what we were seeing in the nursing profession, particularly as COVID was hitting. And so this survey that I'm showing now really builds upon past surveys and includes questions on mental health and well-being, financial impact, perceived organizational support, and intent to leave. Of course, you can go to the American Nurses Foundation and get the much larger survey results there. This was a survey of over 12,500 nurses that was completed last November. And we did 2 parts. We looked here, and I'm showing the results of nurses and their exhaustion level. And it's sad that nurses here we've seen rarely seek professional mental health support. This was as of last November. And 68% specifically said they have not sought the support that they're needing, which demonstrates that we have a lot of work to do to get past the stigma and to give resources in people's hands to be able to provide that. Additionally, what we've done, and because it's really hard to tease out the organizational support from the individual, the work environment and the environment in which they practice really does have, is really important in ensuring the well-being as well of healthcare professionals. And so we've done a survey of perceived organizational support, and it's a validated measure that looks at the general belief by an employee that the organization is committed to them, values their continued contribution, and is generally concerned about their well-being. And what we've seen is the foundation, as they've tracked these indicators over the last couple of years, the scores have not improved over the last 4 surveys. And overall, the scores have been consistently weak, with more nurses strongly disagreeing with the statements than strongly agreeing. The stagnant perceived organizational support data is evidence that nurses continue to need more support from their organizations. And when looking at the segmented responses, it's clear that certain groups, even within our surveys and work settings, are in more need than others. Now I'm going to talk a little bit about some of our results from our Healthy Nurse, Healthy Nation survey. And this is a bigger survey over a longer period of time. And in 2017, we started the Healthy Nurse, Healthy Nation initiative. And we have actually been collecting annual data every year since 2017. So when and to that extent, we've had over 400,000 nurses engage in Healthy Nurse, Healthy Nation to some extent. And so when nurses log on to Healthy Nurse, Healthy Nation, participants are prompted to take the annual survey, which examines the change in their Healthy Nurse Index score over time. So we have comparison data to see how nurses are doing over the last, since 2017, which is really great from a data perspective. So the report explores trends over the last 5 years. And what we look at, we do have some multivariable logistic and linear regression models, statistically speaking, to help us compare these changes and look at estimated margins of error. We also control for a few things in our statistics when we're reporting this data. We control for tenure, we control for race, gender, licensure, whether it's LPN, APRN, priest, RN student, and for setting. So we've done some work here to really look at this. And what we've seen, unfortunately, as you can see by the data, is that despite, we had a peak with COVID, but we're higher than that still when it comes to depressive disorders in nurses. And interestingly enough, in many of our data points, that LPNs had a greater odds of depression than RNs did. They both were way too high, but LPNs had a greater odds of depression and anxiety. And of course, women had greater odds of depression and anxiety than men did in our survey. So we've continued to see trends increasing and not decreasing to our prior states. Additionally, we've looked at mental health, and we've had a continued increase of nurses saying that they have felt more sad, more depressed, more down for more than 2 weeks in the past year. So we've had an increased trend in nurses telling us this, and these are nurses year after year who've given us these data points who have actually increased. So we're seeing an increase in nurses when we compare their data year after year. And then of course you can see how we've broken it down by students compared to the newer nurses and more experienced. So we've seen that more experienced nurses have a lower percentage. And so when we look at maybe targeting activities and targeting specific interventions, those might look different for different groups of individuals based on tenure as being a nurse. And particularly as we're graduating and having residencies for nurses, how are we helping provide resources for those newer nurses? Because we don't need nurses leaving our profession. And this is where we get into a very cyclical issue with being overwhelmed and not having the resources and leaving. So this is definitely a key point for us. And then looking at overall mental health, we've continued to see here in our Healthy Nurse, Healthy Nation that less and less nurses are saying they're getting the emotional support that they need. So we still have a lot of work. And I think as we've gotten over the big parts of COVID, when there was a push, we've kind of gone back to almost a business as usual and not realizing that we need to, this wasn't just a COVID thing, but this is a continuous organizational and professional responsibility to continue to make sure we have this mental health support for our staff, for our nurses, not just in times of pandemics. So leading to, and our other panels will speak to this in much more detail, but particularly for nurses, we know the nurses are at higher risk for suicide than the general population, and that nurses have more known issues about the job or work prior to death by suicide than others. And the reoccurrence of depression is 50 to 85%. So it's important for any nurse affected by depression to receive early evidence-based treatments, which will be discussed later on in our presentation. And then what can, from an American Nurses Association perspective, what resources do we have for you? And the QR codes will take you to each one of those sites, and you don't need to be a member to access the well-being and the other resources here. This is open for all nurses. So the American Nurses Association created a national initiative for the Healthy Nurse, Healthy Nation. And we specifically within that launched a committee to develop resources on nurse suicide. We have a comprehensive website with other resources via the Strength Through Resilience Committee to help nurses. And additionally, the American Nurses Foundation has the Wellbeing Initiative in addition. And if you go into that site, what you'll be able to do is have a confidential stress self-assessment quiz. Then you can connect with resources virtually on your time via phone, text, such as through resources such as Happy or MoodFit. We also have gratitude and other types of podcasts, mental health support guides, and videos for dealing with grief. And additionally, there are infographics. And these are things that you could print off and post in your workplace, post in the bathroom, post in everywhere, for further reach to nurses in just the hallways to help nurses and others connect with the resources are there. And there's also one of my favorite is free and discounted therapy for nurses through the Therapy Aid Coalition and Given Our Hospital Heroes program. So there's just a ton of resources in these three behind these three QR codes, and I encourage everyone to open them up, save them, and pass them along to their colleagues, to help for the next step. So with that, we'll turn that over to the next speaker.
Thank you so very, very much, Jennifer. That was really, the robust character of all these resources and information is really, really important. So thank you for that. Just so that everybody knows, we do post recordings and resources on our website after the webinar is concluded. So check back in to our Compassion Action webinar website, and you'll be able to access materials there. So with that, let me turn this over to Christine Moutier from the American Foundation of Suicide Prevention. Thank you.
Thank you so much. And thank you for that just fantastic overview and data from the ANA's surveys. These issues are, I think we're ready to talk about them more than ever before, as prevalence does rise in terms of distress across all disciplines, really, of health workers. So my task in this webinar is going to be to kind of zoom back out with the lens on suicide prevention at the national level and just do some quick highlights about what the science tells us, what's happening in the movement of suicide prevention that is engaging suicide loss survivors and attempt survivors and everyone in between. And now also the work that's going on within healthcare systems to take care of ourselves, our own workforce and colleagues. And I'll be ending my brief comments with a look at what can we do as individuals if we notice that a coworker, a colleague, a trainee may be in distress, and really just bringing it right down to our own personal level of our work day and our work relationships, and using those for good to support one another. So at the American Foundation for Suicide Prevention, we are a leading national nonprofit organization in the suicide prevention space. We say fighting suicide in the United States, but also globally. We're the leading private funder of all suicide-related research, and that's at the global level. We also have chapters across all 50 states. So wherever you live, know that there's a chapter near you that would love to support your workplace, or you personally, your family, your community, your faith organization. We at AFSP turn scientific findings into these kind of user-friendly types of resources and programs that you see here, just as an example to show that even though we're evidence-based, we really are about the people, because our chapters keep us honest in terms of the real life struggles that we all face when we ourselves or a family member is going through a challenging time and either considering suicide, if they have anyone in your life or in your work arena has attempted or died by suicide. And so we look at suicide as a continuum of suffering and all the risk factors that lead to that risk, and then the support in the aftermath of suicide loss. So please know that there are resources and that you can go onto our website. We also host Out of the Darkness walks. And so this has become something of a movement because local communities all across the United States are coming out. Now 2.5 million Americans walk each year for suicide prevention in our Out of the Darkness walks, which have just started. They occur in the fall season. So one thing that we've learned through both scientific studies as well as through advocacy efforts and the voices of people touched by suicide personally is that language matters. And we have some language that used to imply some of the myths of the past. And even the common phrase commit suicide simply does not make sense now that we understand that suicide is a complex health issue and actually a complex health outcome. We wouldn't use the word commit for issues like cancer or other complex health outcomes. And it does imply something that's morally reprehensible if you think about where the word commit often goes in terms of committing a crime or committing a sin. So we strongly recommend that you try to be cognizant of rooting that phrase out of your lexicon and use plain language like died by suicide, took her life, ended his life. Those are all fine. Killed himself. Those are all considered fine. We also recommend avoiding unintentionally sort of judgmentally laden language like successful and failed attempt. Some of those creep into our clinical language, especially because in many clinical settings, we can get a little bit jaded because we see more of the chronically suicidal and repetitive being hospitalized and presenting in crisis. The truth, though, is that any attempt where we're using the word attempt means that they did not die by suicide. And so you can just say suicide attempt or suicide death for clarification. Okay, and this, I will not do this justice because there's a very, very large body of work going on around the globe in the suicide research field that is telling us more and more about what drives suicide risk and what protects against suicide in real people and real populations in these studies. And one takeaway that we can all walk away here, if you hadn't heard this before, is that in every instance of suicidal behavior or suicide death, it is not a one cause effect phenomenon. There are always multiple risk factors that tend to interact with each other as well as with protective factors. And of course, access to lethal means and the current psychosocial stressors and environment do matter, but they're not considered the cause of suicide on their own. So for example, a breakup or a financial crisis or a job reprimand, none of those on their own are considered the cause of suicide, but when they occur on a bed of other silent, oftentimes unrecognized risk factors for suicide, biological, psychological, and past social and environmental, things like genetic loading, a history of mental illness, a history of a parent with unaddressed mental illness, a family history of suicide, childhood, TBI, and many other risk factors are well known. That is sort of that perfect storm that oftentimes then suicide risk rises when a person is in fact enduring stresses and strains. But remember also that the brain is highly dynamic and plastic in the sense that our thoughts can lie to us. Our brain can lie to us. That can happen to those of us who we might consider like normal in the neurotic spectrum. We're all neurotic to different degrees. But so our brains can play tricks on us. And in those moments of acute suicide risk, even more so, which I'll get into here. Access to lethal means is a key part of suicide risk, and that has very significant practical ramifications for us in the healthcare field, both for ourselves as well as for our patients. So I was starting to kind of mention about the moment of suicidal crisis. These are just a collection of some of my favorite kind of discoveries that come out of the suicide research field, that genetics do play a role, but certainly do not determine destiny, just as is the case in other complex health outcomes. Epigenetics is a very real now part of the pathway to suicide risk and prevention. So that means that just like traumatic events can change the expression of our DNA to create risk, so can therapy and treatment and support and peer support change the expression of our DNA to an opening of protective factors and resilience and even strengthening, if not retaining those innate resilience and protective factors that we all have. We all have very strong survival instincts built into our human condition. But in that moment of suicidal crisis, what can happen for people who are at risk for suicide that is actually different from a healthy control group is that that moment of stress impacts the neurophysiological functioning of our brains in a way that the stress response produces a tighter, more narrow tunnel vision and cognitive constriction, so that in those moments, people are not accessing their usual thoughts, their usual healthier coping strategies, a sense of perspective and long-term perspective. People who have lost loved ones to suicide may wonder, how on earth did they not realize about our love and support for them? How could they do this to us? And those thoughts come out of a place of not understanding these scientific discoveries, that in those moments, the brain is in this tunnel vision, what we call cognitive constriction, which is very temporary, but physiological change in the brain. And so the other ramification or practical takeaway is that if you can help someone live through those acute, usually short moments of suicidal crisis, they do come back. Those are temporary changes in the brain. That can be life-saving if you keep them separate from any lethal means and help them just buy time to live through. Don't see that as, they're just going to go on to find, a different lethal means. That is a myth. The majority of people who live through do not go on to die by suicide. It's greater than 90% in most studies that are all done in different ways. But even for people who have attempted a medically serious suicide attempt and live through it, the odds are they will live out then their natural lives. So there's a lot of kind of motivation that we can have around reaching out and helping a colleague, a family member, a neighbor, a patient who may be at risk for suicide. Okay, let me carry on here. What we know as a sum total then is that this reframing of suicide as a very complex and highly dynamic, but as a health outcome, in that health framework, we can then apply the public health framework to understand that educating the public, making access to effective and equitable and culturally competent mental health care, and that includes for substance use problems, that is one of the most kind of primary and maybe getting into the more targeted approaches to suicide prevention. And then you can go through the tiers of the usual public health approach. And we now have interventions that have been studied and developed for suicide prevention with positive results at each of these levels. So we're in a different era than we were in, even I would say as short time ago as like 15 years ago. We just didn't have the level of scientific discovery and certainly not the level of readiness to implement. We're really at this stage of kind of American history where there's a readiness to invest. It hasn't been done yet, and I believe that's why we continue to see the national rate of suicide rising. After 2 years of downgoing turn, we've seen the last 2 years in 2021 and 2022 with upgoing trends, unfortunately. So the CDC's technical package for suicide prevention, which is for communities, by the way, because again, when we apply a public health strategy, it's not all in the clinical care realm. It starts in the home, in the workplace, in schools, in faith organizations, in policy changes at the state and federal level. These are the list of evidence-based strategies that all of the leading bodies, including my organization and CDC, SAMHSA, that we all agree on. And I'll just highlight a few and think about what it would mean for the healthcare workforce to have an environment that is helping to promote increased interpersonal connectedness, offering debrief. I think about the work of the Schwartz Center and how powerful they have been in terms of that increasing interpersonal connectedness, reducing access to lethal means. Again, if you're helping somebody who is going through a tough time, the most probably concrete thing you can do is help them make their home safe of lethal means for a short period of time while they're going through this difficult period of time. Identifying people who are becoming at risk is another really important prevention strategy, and helping facilitate the connection to peer support and treatment as is feasible. That is a really important. And lastly, any way that we can decrease the barriers and increase access to mental health care and substance use treatment, that has been shown to reduce suicide risk. By the way, in the clinical care space, what I mean by that second bullet point, infusing evidence-based risk-reducing steps into healthcare means, yes, we keep treating depression and PTSD and optimizing care for those mental health conditions, more bipolar disorder, eating disorders, substance use, as robustly as possible. But the new way of thinking in the suicide prevention field is to also treat suicide as its own separate clinical target that would also go on the medical problem list in addition to their primary psychiatric conditions. Okay, something that's happening in the kind of in the national arena of suicide prevention is really being led by some other industries, which is the most exciting way to see change happen. So one example of this is that OSHA, our National Occupational Safety and Health Administration, a branch of the federal government, has chosen to understand that suicide is a safety target that can be impacted by policies and resources and education for the workforce. So we at AFSP have formed, well, at OSHA, they call it an alliance, and we'll be working on materials and resources like the one I'm showing you here that can be posted in any workplace, not just clinical settings, but for example, the construction industry has embraced suicide prevention as a safety target for their construction safety week as well. I know that Judy is going to talk about the UCSD HERE program, but I just wanted to share a quick story with you. When I was at UCSD before coming to AFSP, I had my own lived experience. I then went through the experience of tragically losing a number of physician and nurse colleagues to suicide. And that helped my organization at UCSD get motivated and get ready to actually start a program. And this is something that a group of us worked on launching back in about 2008, 2009. It's still going strong to this day. We've published on it a bunch of times. And again, I think Judy may speak to this because she is now one of the co-leaders of the HERE program at UCSD. So I'll just end by, again, getting very personal to think about, and I would just encourage each of you right now to reflect on, is there someone in your workplace or even in a different part of your life that you've been worried about, that comes to mind when you think, gosh, they just haven't been themselves? And we really say, trust your gut instinct on that, because when someone is showing little leaking signs of distress, it very likely means that it could be the tip of the iceberg. And don't assume that it's on somebody else, that someone else has a better, relationship or better training or something to approach them. We all can do our part, and realizing that support and connection matter. So it's as simple as having a caring, supportive conversation. When you're doing this, you can ask directly about thoughts about suicide. That does not increase risk for people, for any people, let alone people who are in distress. And remember that if somebody, let's say a colleague does share with you, yes, they have had thoughts of taking their life, that's a moment where you need to breathe, ground yourself, stay calm, and realize that in any environment, in any workplace, there are people who are currently having thoughts of suicide. The vast majority do not go on to act on them, but by sharing that they are, they're able to open up their own mindset and their own dialogue. And especially if you're supportive and you're not judging, but you're saying, there's no judgment here. I'm here because I want to learn what you're experiencing so that I can be a better colleague for you, so that together we can make a plan to think about next steps together. So this is what I would call a coffee chat that you literally can have anywhere, as long as it's in private with the person. I wouldn't do it in a group, and I wouldn't do it, rush in the hallway passing. But you can start it out by saying, I really would like to meet with you. And it's purely because I care about you. I'm concerned. And I wouldn't make it opaque, because remember, if somebody's in distress, they're already feeling worried about who is safe, what can I do that's not going to hurt my career or hurt my reputation. So I would come right out and say, when you were at work the other day, you just didn't seem yourself. And that's the reason I'm approaching you now. And purely because I want to hear what you might be going through so that I can support you. I'm here to support you. I'd like to learn more about what you've been experiencing. And that's the invitation, rather than saying, are you going through a tough time? I mean, I would avoid kind of yes or no questions. Keep it open-ended. Let them talk. It's going to be about the circumstances of their life, but the way that they talk about their circumstances will give you clues as to what type of distress they may be having. And if they are feeling overwhelmed, hopeless, trapped, or like they feel like they're a burden, those might come through in little hints that they drop in the way that they talk. And those are all the clues that would that then I would say, when you say that, and I repeat just what they said, it makes me wonder if you're having thoughts about ending your life. And you have to just put it right out there and be quiet so that they can respond, because it is an anxiety provoking thing if you're not accustomed to having this kind of conversation. But I would just try to keep it in the frame of, if you care about someone in your life, and we do care about our colleagues, we would ask if they were going through something, if it was cancer, if it was a family member going through a tough time. We wouldn't not touch it. We would come towards it and express caring. And again, you will not make someone suicidal or make them worse by asking about suicidal thoughts. And conversely, you might miss an opportunity to help them make next steps and make those plans and feel safe in doing so. So the things that you can do if you discover that a colleague is in a lot of distress or is feeling suicidal, you can certainly encourage them to seek mental health support. Remember that suicidal thoughts are a symptom of distress. They're a health symptom. They're not a moment where you drop everything and rush them to the ER. They're not a reason that we need to be reporting on colleagues, not at all. This has nothing to do with competence. The odds are that they're doing their job just fine, because we all are like Teflon coated, Energizer bunnies that keep going to our detriment. So, of course, you can remind them that 988 exists for anyone. You can also, as the helping person, call 988 if you're not sure at what level of risk they are or what to do next. And just remember, you are not their clinician. You're their colleague, or whatever your real relationship is. So I will end there and pass it over to Judy.
Thank you so very, very much. This is such a rich conversation. I'm going to share my screen, Judy. Yes? Okay. Okay. And why don't we have you unmute and take it away?
Yes, thank you very much. Next slide, please. Ooh. Let's see, this is not, next slide, let's see what happens. Yeah, we've missed a slide or 2 or 3 or 4. Okay. All right, there we go. Okay, so let's start here. At UCSD, where I work, as Christine had previously described, She was the founder of what we call the HEAR program, Healer Education Assessment and Referral, with a group of physicians designing a suicide prevention program, the first of its kind, for use in healthcare that was tested and used with physicians since 2009. And then in 2016, we expanded it for use with the entire workforce. And how this works is through an anonymous encrypted screening is the hallmark of the program, that once a year, you're given an invitation by somebody of key importance in the organization to take this anonymous encrypted screening. And the screening covers many different mental health conditions: anxiety, depression, eating disorders, substance use disorder, and you can take the screening without anyone knowing who you are. Then the results go through encryption and are scored through collaboration with the American Foundation of Suicide Prevention. If you score positive for these screens, a message goes to a therapist at your own organization. We have 2 therapists that run this program, and a physician, my mentor, Dr. Sid Zizek. So then the therapist receives a message that someone's at risk, and they can contact them through the encryption. They don't know who they're contacting through the computer, but they know what the results were of their screening, and they try to engage this person in conversation through the computer. Once they've established a connection, then the person can remain anonymous, completely anonymous throughout their entire relationship together. And the therapist may have multiple communication with them through the computer, or they can break anonymity, come in and be seen personally in a private location, or they can have phone conversations, whatever that they request, or by Zoom. Then they can be referred into treatment. So the reason this works, we think, is because of the anonymous encryption. I keep repeating that phrase over and over again, because people still do not feel safe seeking mental health treatment for a variety of reasons. Stigma is still occurring in our, not only in the country, in the world, but in our workplaces as well, and specifically in relationship to fear of what would happen to your job if anyone found out. So the safety is important, to be able to offer a safe way for people to be access care for mental health conditions. And in our case, we have successfully identified and referred hundreds, I'm repeating hundreds, of healthcare professionals, doctors, nurses, pharmacists, housekeepers, the whole gamut, into mental health treatment anonymously through this program. It's been very successful. So next slide, please. You might have to click twice. Okay, next. So this was kind of picked up on our research, our combination of our research, and this work was picked up on by the Future of Nursing report. And now there is a section in the Future of Nursing report for the very first time calling attention to nurse suicide and the fact, a call for action. We need to take action to do things to help prevent suicide amongst nurses. And this screening initiative is one of the things that has been endorsed by many national agencies now as one replicable, cost-effective method for suicide prevention of the healthcare workforce. Next slide. The Academy of Nurses has designated this program an edge runner, meaning a model for replication by others, endorsing this process. And we accompany the process of screening with crisis debriefings too, or emotional process debriefings, so that anyone in the organization can contact one of these therapists and say, hey, can you hold a group meeting for us so we can process the emotions that occurred due to this case, this particular case, and then the therapist will run that. And by doing that, we reduce stigma in the workplace about health-seeking behaviors for mental health issues. And it's become naturalized and normalized at UCSD for people to call for help. At one point, we had to really push the screening process, the yearly screening process, and now people will actually engage in the screening process independently of being asked. They'll go to our website and take the screening because they know they have an issue and they want to connect with a therapist to engage in treatment or help. Next slide. The work done here was also called out by the Surgeon General. We were quite amazed, impressed, and very pleased to see that in the Addressing Healthcare Worker Burnout report that came out last year, that our work had been cited in there as a model for replication. Next slide. Next slide again. And then just as Christine mentioned, the work by OSHA at developing workplace tools for workplaces to help with suicide prevention, the CDC funded this project through the Institute of Healthcare Improvement and the American Hospital Association to develop this suicide prevention toolkit for healthcare executives. And anyone can download this from the internet. Just put in the words AHA and suicide in your Google browser, and it'll pop to the page where you could download this with a list of recommendations of what you can do in your organization to minimize risk of suicide in the healthcare workforce. And one of those is an anonymous encrypted screening process. The other is addressing licensure and credentialing questions to make sure there are no stigmatizing questions on credentialing of healthcare professionals. Often when nurse practitioners and doctors are credentialed by the medical staff office, the questions may violate ADA compliance, asking directly about your mental health conditions and past mental health conditions. And these questions tend to discourage people from seeking the mental health treatment that they might need. So the questions that were once designed for credentialing and even in licensure by the boards of nursing, medicine, and pharmacy to protect the public against impaired employees, it was designed for a good reason, but unintended consequence has been to increase stigma against health-seeking behaviors. So we now know that those questions need to be eliminated from the old data banks, both at the professional level through the boards of nursing and in the credentialing centers of our organizations. What you can do, what every person listening to this call could do, is check the questions in your credentialing for licensed healthcare professionals to make sure that they do not violate ADA regulations, being intrusive, asking about your mental health conditions of the past. Okay, next slide. So this, we've done a lot of research out of our organization on suicide amongst healthcare professionals. This study really blew the lid off of things. Our research team, we have a very large research team of multi-professionals who volunteer their time. All of the work that I'm going to tell you about has been done in an unfunded fashion by volunteers. This one looked at all of the year's data at that time that the CDC had collected about suicide. And we looked at nurses for the first time. No one had ever looked at the nursing workforce data that was hiding within that data set. And you could see the dashed line along the middle being the suicide rate of the general population, female nurses in red, male nurses in black. And you could see for almost every single one of those dots is above the line, meaning higher than the general population. So it's not that suicide among nurses is a new problem or an increasing problem. It's been a problem all along, and we just never knew to look at the data to find out that we were at risk. And this data set ended in 2016, but I can tell you we've looked at 17, 18, 19, it all looks the same. We are still at risk. Okay. Next slide. This was recognized in the Future of Nursing report, as I previously mentioned, with a call for action to take action against nurse suicide because of this data that's been collectively published and repeated by other research teams. It's been replicated. Our studies have been replicated and confirmed by others. Next slide, please. We've looked at physician death by suicide as well, and even though that the physician suicides did not achieve statistical significance greater than the general population, the exact numbers do not matter. Every death counts. Next slide. And one of the things we found specific to physicians was that the the forced retirement deaths occurring around the time of leaving the profession. We found that the time surrounding leaving the profession is a very vulnerable period of time in which organizations really, we would recommend that psychological support be available to physicians leaving the profession prior to when they would have liked to, and a forced retirement either to a medical condition, chronic illness. The other specific thing we found with physicians was that the time of a malpractice litigation is a vulnerable period of time where psychological support is needed. Next slide. So we looked at pharmacists, and we found, again, not statistically higher than the general population the way nurses were, but still an issue here of higher than the general population, especially females, female pharmacists, female physicians, female nurses, all the bar is higher than the general population. And we found a couple of unique findings in pharmacists. The first being that even though they're surrounded by medications all the time, the method that they were using was with firearms over pharmacologic poisoning, as we see with nurses. So this was a curious finding to us. The other finding, you'd wonder why, with such easy access to medications, that be the case. Maybe because pharmacists understand that the medications may not always be successful, where a firearm is a very lethal weapon. But then the other unique finding being that pharmacists would sometimes divert medications for the sole purpose of suicide in the absence of substance use disorder. So that was a key finding for us. We did not see it in nurses and doctors, and that if we were working up a case, an employee case of diversion, you might wonder to yourself, was the diversion for the purpose of suicide and not for drug-seeking behavior? Next slide. So in nurses, the startling, shocking truth that we found was that in those that had a known job-related problem prior to death, 93% of those were either out of work or their job or license had been threatened. And the reasons for the job or license being lost or gone, next slide. Next slide, please, is those three buckets in the middle. My research partner, Ariana Barnes, she developed this model to depict the main reasons. As Christine said, there's biological, psychosocial, and environmental factors in the background, but then the nurse kind of goes through a chronic struggle with either substance use disorder, chronic pain, and the chronic pain can be due to things like cancer, fibromyalgia, musculoskeletal injuries related to work, right? And then prescribed opioids, and then leading to addiction and so there's a cross thing with substance use disorder and chronic pain or mental health conditions out of control. So these things, and then finding themselves trapped in crisis, found impaired on the job or unable to work on the job, losing the job or license or suspended job or license, leading to financial ruin and a tipping point where they just find no way out. The financial piece amongst nurses is kind of unique and really needs to be worked on, is that when a nurse is found with substance use disorder or impaired on the job, more times than not, they are dismissed from the workplace, then they no longer have the benefits they need to be able to access treatment. And we see case after case in the death narratives of nurses that could not afford the board mandated treatment, and that was associated with death by suicide. Next. And just a reminder, once again, that these many cases of substance use disorder that we've seen were related to conditions where the nurse was prescribed opiates as part of an underlying chronic condition or an acute condition, trauma due to a car accident, surgical procedures, fibromyalgia, or cancer. And then at some point, the addiction becomes out of control with access to medications that work divert, and then found impaired or diverting from the workplace and leading to the ruin as I previously discussed. Next slide. So the Academy of Nurses has recognized all of this, and this year put out a consensus statement that we really need to look at the way we work with nurses through these chronic issues, so that maybe we take a treatment first approach instead of eliminating them as a risk to the organization, because once they are eliminated, once they lose their job or license, they can no longer, they're less likely to get the treatment that they need for these treatable conditions. Next. Okay, I think we're going to skip the next couple of slides because we've kind of come to the end of our time together. Skip this slide too. Skip this slide, thank you. I've talked about removing intrusive questions from the licensing examinations, and you can find information about that at the Lorna Breen Heroes Foundation website. Just type in Lorna Breen Toolkit in your browser, and it'll give you everything you need to do advocacy regarding removing those questions from licenses. Next slide. So, in summary, there's plenty you can do. You can advocate for screening of your risk screening in your workplace, the way we do with the HERE program, and has been replicated by many others. You can work on your credentialing questions, and you can work on looking at your state boards of nursing licensing or pharmacy or medicine licensing questions to see if they warrant revision to reduce stigma against health-seeking behaviors. We'll stop there and take questions.
Thank you all so much. There's a lot going on in the chat here. Thanking you. These were really incredibly important and helpful discussions. We will be providing a recording of this website, this webinar on our website, and we'll post the resources that you see here. I think there's a lot of questions about how do I do the HERE program at where I work. So I wonder, Christine, or Judy, Judy, you unmuted. Do you want to address that?
Well, contact Christine. No, no, it's very easy. You really need to have, you need to have a therapist in your own organization or a way to refer people into treatment, right? But contact the AFSP. There's a website, I think Christine put it in the chat, how to contact them at the AFSP to work on the collaboration needed to use their tested and successfully implemented anonymous encrypted screening program.
Thanks, Judy. There's a question about the epigenetics that you mentioned, Christine, and whether you can say a few more words about protective environmental factors and how that works through epigenetics.
Yes, absolutely. I mean, the general concept is that, I think everyone understands that negative traumatizing types of experiences can change the expression of DNA for negative outcomes, but we're now learning that it can go the other way around as well. And so, one concrete example are brain studies looking at both the impact of an antidepressant on brain functioning among patients with depression, but then also cognitive behavioral therapy, guess what, also affects the physiological functioning of the brain. And that's not talking about gene expression, of course, but it's an example of how sometimes it's a little bit counterintuitive that environmental and experiential things can actually then get expressed into our body and leading to positive or negative outcomes. So I really would just say, raising children, or certainly in our family relationships, in our coworker relationships, just don't underestimate the power of creating a supportive environment and safe spaces where people can actually understand that it's human to struggle, and it's a sign of strength to actually be addressing our struggles more and our challenges more proactively.
Thanks, Christine. I know this webinar focused a lot on nurses and, some about the pharmacists. And I wonder if any of you can talk a little bit about physician risk. There was also a comment in the chat about how people in healthcare know much more in detail about lethal means, what's going to work, what's not going to work. which may put, especially, well, any healthcare worker at increased risk. But I wonder if you can comment specifically on physicians, students, and trainees. Christine, do you want to take that one?
Sure. Yep. This is going to be kind of a combination of an actual sort of more like a real psychological autopsy study that did look at physician suicide decedents, but then alongside my and others sort of years of just experience working with physicians and trainees. So it is known that just like with the nurses that Judy's studies found out, that job-related experiences of shame, humiliation, discipline rise up as higher, more prevalent risk factors among the physician suicide decedent group compared to the general population suicide decedent group. And, I would just take that in application. What I think about is how those of us who go into healthcare probably have a little extra load of our own sort of internalized sense of responsibility. We're extra sensitive to wanting to serve, wanting to please, and therefore shame comes too easily to us. And so, I think one of the most powerful things we can do for each other is normalize these human experiences of, again, just facing challenges, not being perfect, struggling, having health issues, having family issues. Those are normal parts of being human, which we all are. So yes, there are some specific things that are known about physicians and physician trainees. And I think there's more commonality, to be perfectly honest, between health disciplines in our approach to suicide prevention than there are differences.
I hate to do this, but I'm going to have to wrap up the webinar, but this has been such a rich conversation. And I want to thank each and every one of you for your presentations and all the robust resources you're offering in these slides and in the discussion. We will post these, and we'll keep the chat to see if there are other specific questions that we can field off to our presenters and then put up on our website. So thank you to everybody who joined this webinar today. It's really been important and incredibly informative. Please take a moment to fill out the very brief survey that we'll send you after the webinar. We appreciate your feedback on today's session. So thank you again, Jennifer, Christine, Judy, to everybody who tuned in. Thank you for joining us and to your commitment to compassionate healthcare. Take care, and we hope to see you soon.